It's time now for the award-winning #1 local talk show in Northeast Pennsylvania, The Sam Lesante Show. Now here's your host, Sam Lesante.
Well, folks, the story of this show is called Cutting Edge and Controversy. That defines his career. Let me repeat that. Cutting Edge and Controversy, and that defines his career. My good friend Tom Meade, excuse me, folks, is my guest today on the Sam Lesante Show and also on the Dr. Tom Meade Show. And we're going to talk about a person who has an experience that you cannot believe. When we talk about cutting edge and controversy, it's amazing what this young man who is now middle-aged has accomplished. My good friend Tom Meade, and you watch him all the time on the Tom Meade Show in real life. And hey, Tom, it's a pleasure to have you on the show.
Thanks for having me.
You're in middle-aged, you notice that?
I'm not middle-aged yet, Sam.
Not yet. What, 35, 36?
Yes.
Tom, I know you for a long time, and we've been very good friends, but every time I look at, what you've done, I say, wow, I thought I knew him for 10, 15 years, okay? But your career on cutting edge innovations and the controversy that, that's been involved, I think the public, the viewers who all know you and have gone to you and will come to you for knee surgery, et cetera, has been explosive, okay? So let's talk about, let's go back to 1989, okay, when you developed formal sports medicine in the Lehigh Valley, which is a fascinating history.
So we all take sports medicine for granted now, but it's probably one of the innovations in my career that I am most proud of, that I brought to the region. But like many innovations, I did not start sports medicine in the Lehigh Valley. I built on the shoulders of a couple giants. I joined Orthopedic Associates of Allentown, and Tom Dixon was practicing sports medicine, for a while before I got there. He was an Olympic team physician. He was taking care of some of the colleges, but there was no formal organized sports medicine program. He was practicing sports medicine, but there was no organizational oversight. There was no program of athletic trainers, physical therapy, education, that sort of thing. And I was just fresh out of my sports fellowship in Cincinnati, and I saw the infrastructure that they developed out there. They were taking care of the Cincinnati Reds and the Cincinnati Bengals and all the high schools, and I wanted to bring that back to Lehigh Valley. Ironically, on the eastern side of the Lehigh River, there was a gentleman who is now my partner, Dr. Emil Diorio, who just came to town a year or two before that to take care of Lehigh University. So he is simultaneously developing sports medicine of the Lehigh Valley over in Bethlehem. Tom Dixon, my partner, is doing sports medicine at a national level in Allentown, but there was no organization to bring it together. So one of the first things that I did is I lobbied our group to have a physical therapy program. So we brought in a formal physical therapy, because after you perform the surgery is only as good as the therapy afterwards. And then I looked at the colleges and the high school on the east side of the river, and one by one we approached the high schools and we suggested the value of putting an athletic trainer in the school every day so they could treat and evaluate the athletic injuries. Back then, what was sports medicine? They had an interested coach that would double as a trainer. They had a teacher that would double as a trainer. There may have been no formal education. He may have been an EMT or something like that. So we put college-educated trainers one by one in every single high school in Allentown, in Deerfield, in Parkland, in Emmaus, in Catasauqua, in Whitehall, in Salisbury, in Palisades, in Muhlenberg, in Cedar Crest. Emil Diorio was doing the same thing on the other side of the river. So the region benefited by Lafayette, by Lehigh, by Liberty, by all of the schools over in Bethlehem getting the same treatment from sports medicine in Lehigh Valley and Allentown sports medicine. So we co-developed this program that exists today. Now it's the standard of care. None of the big institutions at the time, the big healthcare networks, were interested in sports medicine. That was not in their wheelhouse. They weren't doing outpatient sports medicine. They were concerned with the, with the big towers, the complicated heart surgery. Lehigh Valley was the only trauma center at the time. St. Luke's is now a trauma center, but nobody was interested in that space. We developed that space, which is really, really cool. It's probably one of the things I'm most proud of today. So when you look at sports medicine in the Lehigh Valley, it really started with Emil DiOrio, Tom Dixon, and I'm proud to come in after Tom and develop the program on our side of the river. But the Parkettes, the Velodrome, the Philadelphia Eagles, because of my relationship at Jefferson, I was asked to cover their summer camp when they came here for a bunch of years, which was a lot of fun. That's what sports medicine is. Now, Lehigh Valley and St. Luke's have gotten into the sports medicine world, but really it was the role model that Emil DiOrio set up, that we set up, because any sports medicine that's going on now in the schools that they take care of is they provide care, to some of the schools that we used to, and now it's just expanded. But that is really how it all started, and a lot of people, I think, don't realize that, but that's one of the things that affected the population of student health, the concussion program that we started now. It's all what we started way back then. It's so cool.
Now, the Dr. DiOrio he is speaking to, a good friend of mine, is the head of coordinated health, folks, and way ahead of his time. Great doctor. You mentioned about concussion awareness. As you're in sports medicine and you're looking at different things and you see different things, excuse me. I think like anything in business, you do things and you say, oh, we can do this about this particular concern in television or technology. In sports medicine, you learn the different things like concussions. How important was it then, when you were in 1989, 1990, to be concerned about concussions, because now it's a serious matter?
Well, now everybody knows when they look at the data, but really the physicians back there, knew it was an issue. In our literature, it predated what was out there in the public literature. We knew about second impact syndrome. If a football player had a concussion 2 in a row, there were case reports of fatal events after that. So we were very aware of it, but we were up against the media. We were up against the old traditions of the coach saying he just rang his bell, walk it off, shake it off.
Yeah.
And so you walk the fine line between being a trusted team physician, that knew this football player shouldn't be put in, and balancing the traditional tough guy coach where, that was of the era, where, you don't drink water and you took salt pills, the same sort of thing. So, it was a time that you had to dance. Now, thank God, the data proves everything, and now the data comes out, and it's such an awareness at all levels. At the youth level, at the NFL level. Now the recommendations are for soccer players, youth soccer players, not to headbutt, because even the accumulated head impacts before the sutures in their skull are closed can cause trauma. So we're kind of aware of it, but you have to get the public and the press on board before it becomes common knowledge and becomes protocolized.
So as you were moving ahead, with the sports medicine, then we go into you start learning, I think, more about sports medicine, and then you get into medical fitness. So in 1993, you started medical fitness in Lehigh Valley, right? Now, how does that work together here?
So, medical fitness is, I had a passion for medical fitness. I believe that hospitals should not be the center of illness. They should be the center of wellness in the community. And when Elliot Sussman came to town, he wrote a letter. He was just new in town, and he said, I want suggestions from the medical staff. How do we leave a legacy here in the community? And I wrote him a quick letter and said, I know how you leave a legacy. You convert the hospital into a center of illness, into a center of wellness. You should be the pillar of the community that promotes wellness and improves the health of the population. And I think I got his ear, but I didn't get his money, because we started a medical fitness facility. I brought in John Graham from Hammett Medical Center. The Medical Fitness Association just started in 1991. And what's medical fitness? It's basically like a health club, but with college degreed people that understand medical conditions, chronic medical situations that they can monitor, they can take patients in a healthy environment and keep them healthy. It's not just going to a gym and starting. They know, if you have a heart problem, if you have diabetes, if you're overweight, if you had a hip replacement, if you have back pain, if you have rheumatoid arthritis, that's what medical fitness is. It's looking at medical conditions. It's looking at students. It's doing pre-participation physical exams. And, to make a long story short, we did it on our own. I give OAA credit. We started the first medical fitness association at 1243 building, and it lasted for 10 years before one of the hospitals, Lehigh Valley, got on board, and they partnered with us in our new integrated health facility. And now, fast forward, medical fitness is the standard of care in the region. It's probably another legacy that I'm proud of. If you go downtown Allentown, Lehigh Valley now has 180,000 square foot, by the PPL Center, and their hallmark facility is a medical fitness facility that's patterned after what John Graham and I started in the Lehigh Valley. Hazelton Wellness Center up here came down to Allentown when Jim Edwards saw what we were building. So we've really affected how the Hazelton folks up here get, medical fitness, and it's all about pre-participation surveys and knowing the history and knowing the risk profile and measuring the outcomes of these people. So St. Luke's does it. St. Luke's opened a large facility right across from our medical fitness facility. So now medical fitness is the standard of care for our aging population, our obese population, everybody that needs a little extra education and input so that they can exercise safely, Sam, and maintain their health.
In this particular medical fitness, you talk about a program which is started in obesity.
Obesity.
Yeah, which is
we started no obesity. We started that before the bariatric program started at Lehigh Valley and St. Luke's. So it lasted 2 years, and again, it's not what we do, but again, we sort of had the vision to look at this. And now they have the bariatric programs that they put folks in for 6 to 9 months ahead of time. But that's another one of the innovations that was controversial. We had to start it in a different office because even my group wasn't fond of it. They didn't believe on it. So basically, we started that.
What foresight, Tom, to do that?
We just, it's not, you just sort of look at what's going on in the population. And, the obesity rates were going through the roof since the 80s for a lot of reasons. It had to do with the bad advice from the U.S. Guidelines on health and nutrition, the pyramid, that promoted 7 helpings of bread, rice, grains, cereal, 6 to 11 helpings of pasta and, and rice and flour. It made, I could just see the country getting obese. So, if we can't go by some of our government guidelines, as physicians, you just sort of had to look out there and see what was happening.
And often, sometimes when you're on cutting edge, which you do, in your profession, you have to beat the elements. You have to then begin to, beat these so-called pros that, like you said, came out with these things. And so you have the internal, conflicts. Did you have a lot of internal conflicts?
Always. I mean, change is difficult. People do not like change. And there's a lot of innovations we could talk about. It'll take a whole nother show to go through some of the innovations that are now standards of care that we were literally laughed at in the medical community. And I'll go over those. I'm going to engage my friend Dr. Sharkey one of these days, and we're going to go over some of these innovations where we were laughed at, and now you sort of forget. Everybody forgets that. That's now the standard of care. And our latest one is our outpatient arthroplasty, outpatient total joint replacements. It's cutting edge, but we're being criticized for that.
I want to address that. Folks, I'm talking to Dr. Tom Meade, no stranger to our programming, the Dr. Meade Show in real life in the OR. Tom and I started that many, many years ago, and it's been probably the #1 hit that we have on our website. And believe it or not, Europe is like we have hundreds of thousands of hits on the real life in OR. I may have to pull it off because it's more popular than the Sam Lesante Show. But anyway, you could go to our website, ssptv.com, and watch all of these shows. Very informational. But cutting edge and controversy, which defines his career. We come back, let's talk about what he was talking about, the outpatient joint replacement, which is another cutting edge thing. Does it work? Now, we had mentioned that Dr. Meade was coming on the show, and we asked for questions, and we got a lot of them. I want to address some of them, and most of them are pertaining to the outpatient replacement program. And when should you get knee surgery? What happens about injections and the fear, the recovery factor? being the leading knee orthopedic surgeon probably in the country, one of them, I'm sure he'll have some answers for that. Stay with us. Welcome back to the Sam Lesante Show. Folks, my guest today, Dr. Thomas Meade, one of the leading orthopedic surgeons in the country. Folks, just go to our website and you'll know all about it. He's the host of the Dr. Meade Show and also Real Life in the OR. Cutting edge and controversy has been Meade's life, and we're very happy to have him on our programming. You know, Tom, I mentioned to you before that it's interesting because when Tom, my IT man, said to me, we looked at your hits on the internet, and Europe, we have tons of people watching you in Europe, so you're national and international. Okay, speaking of that, okay, you know, your experience, I mean, you know, you deal with not only locally here in the state of Pennsylvania, but you've had people come all over the world for surgeries, right?
Well, yeah, it was ironic. It was 2 weeks ago somebody was asking, you know, about our national exposure, and that week I had a orthopedic surgeon from Oregon come to Allentown to have a special procedure called the subchondroplasty, which actually was developed in Philadelphia by Dr. Sharkey and his team, and I was an early adopter. We had a patient from Maine come down because he had some medical issues and they wouldn't operate him on there, and I had an iron worker from Oregon come up who saw our partial knee replacement, and he needed 2 of them, and we did him, and he went home the next day. So that was just in 1 week. So part of it is the exposure on the internet. Part of it is we do cadaver labs around the country. I do them in Vail, we do them in Naples, we do them in Manhattan, I've done them in Texas. So we teach around the country and people are exposed to that. But it draws in people from, you know, from all over the country, and we do some consulting work over in Europe. We're working with some engineers developing some leg holders. We're over in Asia doing some consulting work. So yeah, it's really exciting. And when you work around the country, and even when you lecture in Europe and Asia, we get patients all over the world. It's pretty cool.
Now, when I said that you were coming on the show, now of course we're showing this show all over the place, but in the greater Hazelden area, folks, if you're on Service Electric Cablevision, you know we're on HD now, 513 as well. Comcast 190 in the Pottsville area, Channel 92 up in the Wilkes-Barre, Kingston, Mountaintop area, and 190 in Lackawanna County on Comcast. So we're available now to close to over 500,000 people. So some of you for the first time are listening to Dr. Meade, but our website is ssptv.com for you newcomers. Just go to our shows and you'll hit Dr. Meade Show, Real Life in the OR, and all of them are there. It's a great experience. But when we mentioned that you were coming on the show, questions, I'm going to summarize them. This outpatient service that you have, okay? Yeah. Now, tell me about that. Who qualifies for that? From what I understand, you go in, you do the surgery, and you're out the same day.
Well, let me just take a step. That's correct, Sam. You take a step back and you look at the high altitude view in medicine, and this is inevitable. This is a force that will not be stopped. In medicine, you know, if you look at the advances between having appendectomies or tonsillectomies when we were kids. I was in the hospital for a week over Easter when I was in 6th grade having a hernia operation. You know, I personally had a hernia operation 2 years ago. I was in the hospital for an hour with 2 little poke holes, you know, in my belly. So that train has left the station. When I was an intern, we would make big incisions and have gallbladder surgery. You'd be in for a week. Now you're out the same day. The same thing is happening in orthopedics. It happened in anterior cruciate ligament reconstruction. When I first started, you were in the hospital for 3 days. That's an outpatient procedure. You're home an hour after the procedure. Total joints are going the same route, but change is difficult because it's in the space of the big hospitals. Most of the total joints are done in big hospitals, which is really only appropriate for a decreasing percent of those people that need the services. Most of these people may not be sick, so it's all about patient selection. With the right patient selection tool that risk stratifies the patient to the right institution, the right length of stay, then you're going to have the safest and best outcomes. So that's what our joint arthroplasty program is. It's not a willy-nilly, let's do everybody, let's do, you know, the 90-year-old grandmother in an outpatient procedure. That is not it. Even if you needed a knee replacement, we have a patient selection tool that's very extensive. You have to go through and we would score you. And we would decide, are you a good candidate for outpatient or inpatient surgery? That being said, if you are in the 10 to projected 50% of total joint patients that would fit in there, it has been an unbelievable ride. We've just completed our first year. We've hit almost 100 patients as an outpatient. We've had no medical readmissions, and the patient-reported outcomes are phenomenal.
So you have to qualify for this, first of all.
You have to qualify.
Okay. All right. With that being said, the other questions we had is that, number one, a lot of people have problems with their knees,
Yes.
right? And sometimes they feel, everyone's always worried about surgery. You know that, okay? And every reason for
Correct.
that. So when and the best tool is, folks, I highly recommend, if you need knee surgery, et cetera, just go to our website, Dr. Meade Show, Real Life in the OR, you'll see the procedure. You'll see the procedure that Dr. Meade does, and then you'll have a good idea of what the procedure is. But sometimes they say, well, maybe injections will help, okay?
Yeah.
What about that? What about that mindset?
So, Sam, and part of the patient selection is they have to go through this selection tool that says, have you exhausted all of the following criteria? One of which is injections. But you can go down the list and you can go through the simple things: rest, ice, activity modification, lifestyle modifications. Do you stop what hurts? Are you impact loading? Are you 20 pounds overweight? Have you tried non-steroidal anti-inflammatories? Have you tried acetaminophen? Have you tried a knee sleeve? Have you tried a knee brace? Then you go into the injections, and the two big categories of injections are, steroids and the hyaluronic acid injections. And there's very few, if any, people that have a partial or a whole knee replacement that haven't tried these, because some of the results are remarkable. Even though they just treat the symptoms and not the problem, if they treat the symptoms for a year or 2 or 3 or 4, which we see, then you don't need surgery. When that stops working or they become less efficacious, some people respond to the steroids.
Okay, so not to interrupt you, but okay, so let's say you go that path of the injections. Yeah. Now, what has been your experience? If we have 100 people that have been doing the injections, et cetera, and the inevitable comes in, do 20% of those end up in surgery? Do 50% up in surgery? What's the percentage after they tried all that stuff that they finally end up in surgery?
I guess it depends how you play the statistics. If you look at, let's say, the people that are having knee surgery, almost 100% of them have had the injection. So you could look at it backwards. If you look at it prospectively, you can save a lot of surgery on the injections. Think of it this way.
They work, though.
Oh, they work. So I'll take your number. 100 patients that get a steroid injection, 95% of them will get symptom relief. They will feel wonderful.
That they will never need knee operation.
What I can't tell you is how long it will last.
That's the thing.
So it will last. It could last a week. It could last a month. It could last a year. And if I drew the bell-shaped curve, the average steroid injection will last about 3 months.
Okay. So the point is that they end up in surgery.
A large percent of them can.
So the objective here is that if you know it's bothering you, the recommendation would be get the surgery done, because you're going to get surgery done anyway.
Well, it's a quality of life issue, and you have to go through it with every patient, and it's elective.
I got a minute and a half left. I want to ask you this. Why do you limit yourself to practice just knees?
Well, I did that in 2004 when we were building a new facility, and I thought it would give me more administrative time to build a new facility that I was building. But ironically, I was, certainly the only regional surgeon that limits his practice to knee surgery, and it backfired clinically, if you will. My knee practice went through the roof. So, it was a good thing for me professionally, because I'd rather be a surgeon than an administrator.
How many surgeries do you do a year?
We do a lot. We do probably over 1,000 knee surgeries a year. Mm-hmm. Yeah.
So you're slacking off on a job, huh?
Well, I have a great team. I have a great team, and on another show, I'll show you why we can do that, why it's safe, and why even with that number of surgeries, I do the entire surgery other than closing the incision, which my PAs do, and they're better at it, and all my patients know it, and they're aware of it up front.
Well, the thing is that, you know, you've been ahead of your time, and the fact of the matter is that there should be no one out there suffering with knee pain, because you have the solution there.
Thanks, Sam. It's always a pleasure being on the show.
Now, listen, I've taught you enough now. I mean, you have to teach, you know, do what I teach you and then move forward. But I'm looking forward to the show that you're going to have with Dr. Sharkey, because I think there'll be a lot more said about what you do and why, okay? And that's the whole purpose, educate, educate, educate. Dr. Thomas Meade, folks, one of the leading surgeons in the country. Proud to have him as my friend. He's been with me for many, many years. He's a first-class person. And he has that bedside manners like you can't believe. Just a great guy. We'll see you next time.